Today, we are discussing about the very important topic of mental health and how AI might help or harm mental health. In particular, here we'll discuss with Matteo Pinna, who is finishing his PhD in behavioral economics at ETH Zurich, and he's the founder also of Safespace app and a Safespace Research. So basically, Safespace app is an app to help students with mental health, and it's based on a generative AI, so on a large language model. So in this discussion, we really focus on how GenAI can help with mental health and the pros and cons for using GenAI for mental health. And we'll start the discussion with this very shocking example that I've seen circulating on social media of a person saying that they were depressed, they wanted their life to end, and then asked ChatGPT to create a reminder to buy a gun the next day, and ChatGPT creates this reminder. So we start with this example and explore scientific research, evidence on the use of GenAI on mental health, as well as discussing the project Safespace created by Matteo Pinna. Hey Matteo, it's a pleasure to have you today. It's a huge topic that we are going to discuss, where actually you have a lot of discussion, lots of debate about adverse effects of ChatGPT, of GenAI in general on mental health, as well as potential avenues to support mental health. And you're exactly working in this world, in this realm, with a startup, but also during your PhD that you're finishing now. And I wanted to start with this example that I witnessed online, and we exchanged about this example. It was when ChatGPT released this tool to create reminders in your agenda. You have a person who basically started a chat with ChatGPT saying, well, I'm depressed, life is tough. Could you please create a reminder to remind me to go buy a gun tomorrow? And ChatGPT does it. It creates the reminder. And basically, I wanted to start with this very shocking example that connects GenAI and directly potential adverse effects of using these tools for mental health and support for mental health.
Thank you so much for having me, Quentin. It's indeed it's a very important topic, and it's one that is very dear to me as a PhD student. I've gone through my fair share of tough moments in my journey, and as well my colleagues and friends, and so it's a topic that I care a lot about. And I remember the exchange we had about this post that came out, and I was as well initially shocked about it. My first reaction was to think that the post was fake, that that was not possible because it was OpenAI, and I thought, hey, this is very easy to take the image, so it must be wrong. So I went to ChatGPT, and then I ran I ran it 10 times, and then I figured out I could replicate the issue most of the times. Of course, after the initial shock settled, I realized, of course, that this was a different feature. There was not really the journaling feature, and that was still like a beta feature, and this was like an edge case that can happen when you're beta testing things. But for me, it was an important reminder that of the importance of specialized tools. So as it is now, ChatGPT is probably the best, arguably maybe the best chatbot available, maybe together with Claude. But it's meant to be a general usage chatbot, and it's not been built to help directly with mental health. And so these edge cases can happen. And then the other part of it is there is this view around that chatbots shouldn't be used for mental health. And we could, spend a couple of hours having a fun discussion of is this, should they or should they not? But then on the other hand, the way that I see it, or I think about it, is people were already using, non-LLM chatbots, like rule-based chatbots. I don't even know, for 40 years. Well, I think the first one was in the 60s. It wasn't that good, of course, but they have been for a long time. Now we have these large language models based ones. They are better, but let's say we still have this question. And then what I say is people are already using ChatGPT for mental health. So the only thing we can do is not make LLM-based tool that is meant for mental health, and then people are just going to use other tools that are not meant for it, and this create like a possible dangerous situation in which this not only just edge cases, but like any possible risk case is not remains unaddressed. And this is what's been happening. So when we look at this post, if I remember correctly, the person was using the AI chatbot from his workplace. I'm not sure what kind of chatbot it was, probably for like administrative tasks. So he tried to, there was, am I confusing the two cases? No, no, okay. We talked about two cases maybe. The first
Yeah,
one
it's
was this
about yeah.
person.
Mhm.
Sorry, I'm confusing the two different cases. One was just these reminders from
Yeah.
ChatGPT, but then there was another case of an article that came out of a journalist that used his admin AI chatbot from work and talked about suicide, and then the chatbot also gave some toxic advice, and so again, what happened in this case is the chatbot was just meant to do admin tasks and it was not meant for mental health, not even to be used as a chatbot in general. And this is happening not only there. I also know from a fellow startup founder who is building an AI teacher for teaching code to little kids. It's like awesome project. It's really crazy. Kids are very good at learning coding, and then they can learn very well with this AI teacher. But then he realized that the kids were starting to express their emotions and feelings, especially talking about family situation with the AI teacher. That wasn't meant to be, of course, a mental health support. But so my point is, you can either give people an obvious choice, like a tool to help with their mental health, or they're going to try to find it in places that they shouldn't.
So two things that comes to my mind is indeed you cannot prepare for you mentioned these edge cases. I mean, sometimes in image vision this is called the long tail. Basically you have all these situation, and if it's not in the training set, it's very hard to think about all the possible situation that could arise. And if you don't have this, well, for a prediction or for different algorithm in AI, it will be hard to make the good choice, the good call. And also something that I realize here is your main thing is also connected to how we use it in general. You have a lot of shadow use. For example, in companies, a large survey, a multi-country survey has been made, and a few months ago, and about half of the people in the workplace used GenAI tools, LLMs, that were not authorized on the workplace. And hence, basically, your advice is something I also advise companies on, and I've been working on, and many people. It's basically people will use these tools. So let's arm them to do it properly. Let's raise awareness about the dangers, where it works, when it doesn't work, why, how can you work efficiently, because they will be using it. So prohibition is not the right solution, because you just take your mobile phone and you get it. So prohibition probably won't work and even destructive. The second thing that I make me really react here is the fact that children would quickly exchange on a different topic and personal topic. And
Mhm.
based on your expertise in this domain, why do people like do this? In the sense, do they feel? Is it because it's not a human, so they won't feel judged? Is it? Do you have any idea why we might be willing to confess easily to an AI?
I think there is something in the literature. People tend to, when they are depressed or they have symptoms of depression, they tend to feel more lonely. They feel like um, there are issues with self-esteem. Um, and this comes not like when I talk about self-esteem, or like when, in this case, it doesn't mean just um, I don't think I'm good enough at something, but just I think I'm not good enough to even deserve, love or support or any kind of thing. So they tend to, people may tend not to want to bother friends. And so a chatbot can offer a resource that allows you to get support without going into that issue. Again,
Mhm.
my background is not in psychology, so I would say like a psychologist is better suited to answer this. But consistently with, because even our data from the pilot of Safespace, like what we see is that the highest usage was late at night, I think after 10 and before 7 or 8 a.m., so very early. And that's when people, I mean, we don't know exactly why were they using there, but I would say a safe guess is that they couldn't fall asleep, or they woke up and couldn't fall back asleep very early. And then needed somebody to talk with, and either friends are asleep, so you feel lonely because you can't reach out, or even then, let's say your friends are awake at 11 p.m., but still maybe you don't want to bother them. So I would say this is consistent with this issue of reaching out. And
Mhm.
one, maybe a small addition I can make is that we asked the students from the pilot of Safespace if they had friends to reach out to. Like, do you have, I think the question was phrased as, do you have people in your life that you feel safe, or like that you can reach out to talk about emotions, or along these lines? And most people had a person or two. I would say 95% of people had a couple at least. And so the issue is not that people don't have friends to reach out to, it's like they still don't reach out. And not this is not news, right? People have friends, but they don't want to bother them. There's the stigma of mental health. There's just this guilt of reaching out. And yeah.
And here, chatbots could help, I mean, to make this step. Or, as you said, I mean, one of the benefits and problems sometimes is that it's always available. And sure, it could be destructive for learning. For example, it might be you always feed answers without fighting a bit, trying to acquire knowledge. That's a different topic. For mental health, it sounds that indeed here it can not necessarily replace, but fill a gap. It's 11 p.m., it's maybe 1 a.m., and you're stuck with thoughts that are just negative thoughts, and you cannot reach out to your friends, or you don't feel like it, or even they don't reach out because the mobile is turned off. So what can you do? You wait in the morning, you feel really bad, or maybe worse things could happen. But here, basically what these models could offer is you have this availability, and it could help to reach out at any point in time when other people are not available. So that's definitely on the positive sides of these LLMs. But maybe tell us more about safe space or safe research. I'm not sure now. Safe
So
space research.
Safespace is
Okay.
the app, and Safespace Research is the startup.
Okay. So
Um,
yeah, tell us more about this.
yeah, I mean, maybe I can start like following up on what you just said about the issue of it's available 24/7, so people might replace their friends or therapy or human contact with it. This is like a common concern that people have. And so there's quite a divide in the startup scene on what should these chatbots do. Some people explicitly say, oh, we will replace therapists. That's our goal. At SafeSpace, that's not how we see it. At least not right now. I mean, I cannot say, I don't have a crystal ball. I don't know in 50 years or 100 years, like whether maybe chatbots will be able to do as a good job as therapists. I don't think they do now. And also the human contact it's a very big part of like our social interactions and like how, yeah, our lives. And I don't think we should replace those either. And so the way I see safe space is, yes, it's a support that is 24/7 available 24/7, and these can help you to cope with symptoms, or cope with a potential panic attack, or low moment during the day in which you cannot access any other resource. That being said, what we want to do is integrating human support as much as possible in the app. So Safespace is a mobile-based app, and it has, of course, a chatbot that we call the diary or journal. We look at it more like as a self-reflection tool that as a feedback. to make it easier to do the diarying or journaling. But the other part is the support group that we haven't piloted yet. But the support group tries to build on this idea that depending on the level of distress detected or the topic, it might be better for the person to try to reach out to a friend. And yes, maybe at 5 a.m. you cannot reach out to anybody, but there's also like hotlines and other resources that are available in those hours. Especially, like, we are lucky enough in Zurich that especially also ETH students, they have access to, like, there's a hotline that is called Nightline that is available till I think midnight or 1 in the weekends. There's the Botene Hand, I think it's called, like the friendly hand, that it's a service available in Switzerland, and it's also I don't think it's 24/7, but it's open most of the hours and available in multiple languages. And so, this is what we try to do at Safespace. We try to understand, together with, of course, the feedback for ETH with the counselors, and some of them are also psychologists from the student services, the counseling services of ETH. What should the app do in certain cases when there's, for example, self-harm risk, when there's some level of distress, and then the app will provide the resources for those situations. And in lighter cases, the app may say self-reflection, just guide the self-reflection. In other cases, it might say it could be good that you reach out to a friend, if you reached out to a friend. And once the support group will be fully implemented, then ideally the app would also say, hey, like, you have these friends in your support group, why don't you try to reach out to them? Because this is what therapists already do. When you go to therapy, one of the first questions that they may ask you if you're going through something is, okay, do you have somebody that can support you from your in your life, your brother, your one of your parents, your best friend, your partner, whoever this person is, they ask you. And then what we want to do with the support group is creating some sort of behavioral tool, if you will, like a commitment device that then the counselor can say, or the person itself, okay, I put these people in the support group, and the support group makes it easier, simplifies the process of reaching out. And the chatbot can also remind you of that. So the chatbot, yes, it's a tool available 24/7 that can help you cope with the symptoms of distress when you're in distress. But on the other hand, it's a low barrier entry to get support from friends, therapists, professionals, or in the worst cases, emergency resources. This is how I would see it, like, as a low barrier entry point to mental health support.
Is it free?
Can you say that again?
Is it free? Is it available for anyone? Is it something you're launching now and scaling up? What's the setup so far?
So at the moment, it's only available to the students who go to the counseling services of ETH. So if you go now, and depending on the situation, it's like based on the judgment of the counselors, they may advise you to try the app out. And like, the goal is to have it offered to the whole student population in universities. So our targets are universities, so we would sell it to universities, and then it would be free for the students.
Why is it for universities? Is there a particular reason?
I mean, as I said earlier, I'm a PhD student, and like, for me, I mean, when you're building something, you have to know your target group. And so the target group I know is students, because I'm a student. I've been a student for the last too long. Yeah, like, I mean, there's high school, etc., but then like bachelor, master, and PhD, that's like 12 years of higher education. Yeah, so I knew that target group, and then I could kind of think better and understand better the points from the counselors and therapists about what are the needs for students. And also, I mean, there is a clear problem there. I mean, of course, mental health is a global problem. It's not just universities. But if you look at the data collections on universities, they are, I mean, I would say the data are catastrophic. If you look at, there's these 2 papers. One is on grad students in the US, and one is on econ departments in the EU. The second one is co-authored by Elisa Macchi. You might know her from the University of Zurich Department of Economics. And they did a data collection on econ departments. But all this data collection basically showed that there's something like a 50% rate of students, like around 40 to 50% of students have symptoms of depression. And then something like 1/5, I think in the paper on the econ department is 17% maybe of students had suicidal thoughts in the 2 weeks before the survey collection. Like almost 1 out of 5 students had suicidal thoughts in the 2 weeks before. And if you look at the ETH data collection, there's one from 2019. I'm not going to say a percentage because I don't remember exactly, but it's kind of similar. But the question was different. I think it was, I've had suicidal thoughts for at least 2 weeks in the previous 6 months. I think 2 consecutive weeks. Anyways, the number was similar, also roughly 1 out of 5. Please double check these numbers maybe, but like those are the rough numbers. And this is much higher than the normal population.
So with your knowledge, because with mental health, and I mean, I'm obsessed with data, I'm working with data all the time. And typically here with mental health, you always have measurement errors, right? You might have people who hide or who, for them, it's easier to say. And I'm just wondering, saying it could be qualitative, your answer, just whatever you think about this. In this situation, could it be that people with higher education level have it's easier for them to share, to say this in a survey and to identify actually and say, okay, hell, I'm going to, indeed, that was this kind of thought. I feel depressed. I was exposed to this terminology. I know that people are seeing psychiatrists, like maybe in other strata of the population, it's still more something that you hide, and hence it affects the detection rate. Anyway, I think this doesn't prevent us from saying what you just said. The statistics are there. It's incredibly high. We must act. I'm just curious about the quality of the data and the potential bias with other strata of the population and what you think.
I 100% agree. There's, some sort of there's a selection into higher education. There is like bias in like a sample bias in there's even data collection bias. Maybe the people who choose to do the survey are more interested in mental health and therefore choose to do it. Even though, for example, for ETH, in the new data collection, the one coming out this year, there's some preliminary data. If you look for them, they are consistent, slightly worse than 2019 collection, or 2018, or when it was. It's a big part of the population. So I think the like sample bias of the people, can we call it selection into treatment? Not really. But yeah,
at least you have a good representation to make it.
You have a good representation, to say the least. Yeah. But definitely could be, people who are who study in higher education, they are more likely to have higher income, so they probably have better access to healthcare. They are more likely to have parents that have higher education, and could be that there's less stigma in mental health with people that have higher education background and all these things. So for sure, it could be that the general population has similar rates, but just the students in university are more likely to report it or even be aware of it. But on the other hand, so this would hint that this could be overestimated. On the other hand, when we look at this is very small sample, like we are talking about 50 students, for example. But in these 50 students, we got data from ETH. We saw that they're perceived, or we saw a hint that their perceived mental health, self-reported, like how do you feel on a scale like 1 to 5, was slightly better than what they scored in the depression scale, like PHQ-9. for. And so this could also hint at that the students think that they do better than they actually do, because you're surrounded by people that are also stressed. And so everybody, I mean, this I know even from my personal experience, like you're in the PhD and you're like, oh, I'm stressed, like I'm not sleeping. Oh yeah, me neither. Like I didn't sleep last night. Oh yeah, me neither. So it's normalized sometimes to overdo, to push, to be in this how do you call it? Discomfort zone, maybe. That, there's some points that being in this zone can help learning, it can push learning, but on the other hand, when you're too much, like there's levels in which it can be damaging
Yeah,
for your mental
exactly. I
health.
mean, if it's affecting your sleep, your behavior, your emotions, I mean, it won't be a good discomfort even for learning. It's clearly at least that it's affecting your sleep. As soon as it's affecting your sleep,
Yeah,
definitely you're passing. Again, I'm definitely not in this realm. I'm doing statistics, so no advice here of any sort of anything. But yeah, I think it's
yeah,
safe to say that if you're not sleeping, it will affect in a negative way all the different aspects of your life.
yeah. I think even as economists, we can safely say that not sleeping is not great.
Mhm.
But yeah, so it might, like this would hint, for example, that what is found in the what students think. Yeah, they might think that they are better off than they actually are.
Mhm.
So
Mhm.
under reporting when asked directly. But this is why the assessment scales are a better tool than just asking how would you rate your mental health on a scale
Yeah.
from 1 to 5.
So one thing also you mentioned this mental group and the fact that the app you're creating will someone suggest to turn to a human. How do you see basically the role of AI and human intelligence and human contact in in this question of mental health? What's the pros and cons, and how should we basically efficiently mix them?
I would say, okay, let's start with the maybe must not do, or like at least for us, what are the no-goes. There has been one startup, Coco, I think it's the name, and they were offering peer support, AI enhanced peer support. And I mean, there was a bit of a scandal about it because I think the people that were receiving help, they couldn't see, or they were not made aware on whether the content they were receiving from their peers was AI written or not.
Ah,
And the peers had an interface that could help them with advice for the answer, and they could select like the AI generated answer. But then for the receiver, they didn't know if it was. I mean, it was still the human,
I see it's a mix, but
like
not clear.
it's a bit of a, but unclear to say the least.
Uh,
And but then another issue is in general, there are a lot of communities online. There's a big community on Reddit for in different subreddits on like depression
okay.
or neurodivergencies. They can be like ADHD support, OCD support, PTSD support. Like there are nice communities, and the moderators do a great job in try to handle everything. But this is like public, and then you can have multiple moderators. The other users act also as they can downvote, upvote, they can signal stuff. But when you are looking into a one-to-one peer support, then you need moderators that can access the conversation, and this is hardly scalable. So this is an issue that things like Coco might have. Like when you ask people that you don't know to support other people, you may have some people, some ill-intentioned people. And a moderator, even it's hard to say that even a moderator might not be able to spot that, because they look at single shot interactions overall. But then like more subtle negative behavior could be missed by a moderator. And I mean, even if it's not, willing negative, like it's not ill behavior, but it's just like inadequate support, yeah, this could also be a problem. But so the way we think about it with Safespace is to try, instead of finding new people to support, starting with the idea that most people have friends or peers that are willing to give them support. Even if they don't think they do, they likely have somebody that would be happy to give some form of support. And then to make it easy to reach out to them in terms of logistics, and nudge them to do so via the app and the chatbot. So this is how we see it. And I mean, of course, there's the other, again, so I would say, I'm just reporting some other people's views. It's not necessarily my view. But some people argue, hey, but therapists are also not perfect. You might have a therapist that is not that good and does more harm than good. Maybe not on purpose, but just because they are not as well prepared to treat a specific condition. This can happen, like especially in the realm of neurodivergencies. There has been this issue. Like there's a wave of new therapists focusing in ADHD, as it has been started to being diagnosed more. It was quite undiagnosed. Same with other things like sorry, just double checking the acronym. It's ALS. Yes, with ALS, on the autism spectrum as being diagnosed more, and then you need therapists that are trained to deal with these cases. Because, for example, when you look at these conditions, they're also often comorbid, like people with autism are more likely to have ADHD and OCD. And for example, there's some evidence that talk therapy doesn't work with OCD, or doesn't work as well. So a therapist that is trained in talk therapy and not in CBT might not be a good fit. And it's not because they are not good therapists.
What's talk and CBT? Can you just say?
Yeah, so talk therapy is more like the, how would you call, the classic therapy in which you go and talk about your problems, share. And because conditions like OCD have big problem with rumination and looking for insurances, but mostly rumination is a big problem. Rumination being overthinking and going on and on about specific thoughts without stopping. So talk therapy might encourage that and therefore worsen the symptoms. Instead, CBT, cognitive behavioral theory, has a bit of a different approach. And it's, again, I'm not a psychologist, just a very passionate person about it. I also don't mind sharing a bit through my own journey of therapy, as many of my PhD colleagues have. And so the idea of CBT is more that like your brain is quite, as I think the way to say this, has quite high plasticity, therefore is able to, in a way, reshape itself. Like the neurons connection can change, and by repeating, like with consistency, some train of thoughts, for example, positive reframing, or like looking at the biases in our thoughts patterns and systematically reframe them by saying them out loud or by diarying or whatever the way, this can help you like literally change your brain structure in a way that can help cope with symptoms and depression. Again, not a psychologist, please double check these things, but this I think is the idea. I was like, at least my understanding of it.
Yeah, it's really interesting. I mean, what you mentioned also with the quality of AI. I mean, for diagnosis, medical diagnosis, I haven't seen something specific with respect to diagnosis with mental health. But I just seen again a paper published, or maybe a working paper, but these days on LinkedIn, which showed that the diagnosis and the capabilities and the results from these GenAI tools were better than the average doctors. And again, so it reflects that you have space for potentially good collaboration, these tools being used by actual doctors to improve their diagnosis, but it's not that simple. It's definitely not that simple. And as we said, also, you have the thing that some things that can be detected by humans, also that are subtle, that are maybe out of the training set or for some reason, it's good also to have a human in the loop. In particular, to be sure that you don't have these edge cases, this long tail situation where basically you have something that was unexpected and you have a very destructive advice suddenly. On average, you're doing better, but suddenly you have something really destructive. And that's where also we were discussing about this interaction between human intelligence and artificial intelligence. And I mean, so far, typically for very serious topics like mental health, healthcare, it could be cancer detection. You have to have a human in the loop and an expert to be able to confirm, to judge, to be sure that it's a valid advice. And also for the destructive side, I mean, you mentioned some different way to work with LLMs. For example, this company with this mix where you're unsure if it's a human who is talking to you or if it's just AI generated. I've also seen a company, I'm not sure what they are doing now, but that were basically creating clones of your loved ones for when they die. And you can see how, I mean, uh, moving forwards, I mean, making you, I'm not sure about the word in English, but basically accepting this death, how it might be destructive, because you might be keep discussing with something that's completely virtual and telling things and getting answers, but it's not the actual person. And I think I see also many ways how this could be destructive. And I mean, there was maybe something you clearly have seen, I guess. It was this, at least one documented case of a young person who fell in love with his GenAI tool, and who killed himself at some point. Do you know this story?
I think it's been a while now. It's one of the earlier AI tools. Yeah, I remember this story. But to just maybe just thinking about what you just said overall, I mean, first I want to say I do think there's a Black Mirror episode that it's called something like Memory of You that does that. So that's that like my first thought is being a bit scared. But on the other hand, we are also like I would say there's always the debate: are economists scientists or not? They say we are some sort of scientists, and what I could argue is that there's VR reality as being used to treat PTSD in soldier post battle and in other fields. So who am I to say that creating an avatar of a dead person cannot help processing grief? I don't know. In a safe environment with the supervised environment by an expert, it could be. I don't know. This is not my expertise. So I also always try to do this game in which I try to separate what is my gut feeling reaction on something and what do I know about it. So my gut reaction is, oh my God, that's creepy, that's dangerous. But on the other hand, if you had asked maybe somebody 20 years ago, like, oh, would you want to see a different reality on VR? They might have told you no, because people are going to start living in a fantasy world or whatever legitimate concern they might have. But then you see these studies and you see that they can actually help because So I always say, let's stay open about things, but it's important to be careful, of course. So this is about that app. On the other hand, I know there's apps on the market available on the App Store that allow you to create a replica of your lover or like let's say a fake partner, completely unregulated, of course, or like I'm skeptical also there, but again, I would leave it to the experts to evaluate whether that's potentially dangerous or not. But so one thing that comes out of this is evaluation is important, and this is why, for example, with Safespace we are partnering with. I mean, of course, part of it is my original ETH research group that does research on LLMs. But also the University of Zurich psychology department to keep doing evaluation on things. And as we go forward, we are still, understanding how to do this, but basically how to address the conflict of interest. And the way we look about it is that we are going to give the data as raw as we can to the researchers and then let them ask the research question. This is like the cleanest thing we can do. Because my thought was initially, I have these ideas, I'm a researcher, but I might have bias I'm not aware myself of because I'm also developing the product. So I shouldn't be, of course, like we do our own evaluations internally, but then the people who are evaluating scientifically, they should come up with the questions because my research question might be inherently biased. But so evaluation of these tools is important. There's various things that you can evaluate, but overall what we care about is to say that it's not dangerous. It doesn't decrease people's mental health. And it's a tough assessment, right? Because, if you cannot just give a person the tool and then say, hey, look, but after using it for 2 weeks, their mental health is lower, because mental health can go down. It can be like it goes into waves, or like, if it's more than 6 months, somebody gets I think it can be diagnosed as clinical depression if you're depressed for more than 6 months. But yeah, it can be that you're worse off and it's not because of the app. And it could be that not everybody is benefiting from it. So there are all these issues, and this is why evaluation is important, evaluation done by scientists. And there are, as much as possible, like isolated, or like they're unbiased from the commercial revenue of the company.
Yeah. So basically what you will do, just to also, because of course that's the topic that's the dearest to my heart, causality and causal AI in particular, that could be useful here. So just for also the audience, so basically what you said is, the thing is, if you do a pre-post analysis, you look before people using it and afterwards, it's biased because, for example, you might reach help at the moment where it's getting worse, so you really feel that you need it, and basically you have this trend that started before and you see that it keeps going down. Doesn't mean that it's bad to use the app. So basically the core idea is to find a good control group. And in your case, what will be the control group ideally? How do you compare? Yeah.
I mean, this is the big question. What is the control? And I mean, first of all, I will leave this choice to the researchers. So, for example, Timon Elmer is a postdoc at University of Zurich Psychology Department. He works on social networks and well-being, and he will be the one leading the research effort. So he will come up with the support group. Of course, I have my ideas. When you look at the literature, also this paper that you mentioned in the intro, like there are various ways to go about it. Some people do an information treatment. So you just give your control group, some material to read about it. It could be even the same material that the chatbot does information retrieval on when answering a specific set of questions, so that they're kind of like comparable. But then we were also thinking, are we evaluating the impact of self-reflection, journaling, or a chatbot? So another control could be having a written journaling, and that could be more similar. But on the other way, the chatbot does give some form of advice based on some context for maybe a journaling and content. It's tricky to find, but having, of course, as many information as possible collected, doing it via, for example, one way to have more control on which phase of the when did the person start to use the tool later in their as they were getting worse and worse. So it was like at the beginning of the symptoms of distress appearing, like running this with therapists, so more of a clinical setup could also help with that. Because for now we are doing it with counselors, and we don't know as many details. We just trust we have this survey data collection. We ask a lot of questions, but of course we also don't ask them to do a 2-hour survey, because if you're not doing well, you cannot do that, maybe. And yes, so switching it to a more clinical setup could also help with that. But we have to in a way, generalize for context, because again, maybe we can control all these factors in a clinical design. We find it helps, but this doesn't mean that it helps people in a non-clinical design. Maybe it's the connection with the psychotherapist that helps. Maybe in our case was the connection with the counselors. So I would say there's these papers that are slowly coming out evaluating, and as it is with new literature, the more papers we have, the more data collections, the more experiments we have, the better understanding we will have slowly how things behave in multiple setups with different like sample representative of different populations. Like ours, it's maybe students. Other can be general population, companies, or like the
elderly
more
people.
studies we have, elderly people, different control groups compared to journaling, compared to an information treatment, compared to, I think in the study you said they were just that they could use the app later on. I don't remember now
Yeah, exactly.
what was
So just because I mentioned this off, I think before we started filming. So basically, there was this randomized control trial with a bot called TerraBot. And basically, to summarize, they said we conducted a national randomized control trials of adults, 210 adults, with clinically significant symptoms of major depressive disorder, generalized anxiety disorder, or a clinically high risk for feeding and eating disorder. And participants were randomly assigned, indeed, in a 4-week TerraBot intervention, or a waitlist control. So basically, indeed, for 4 weeks, the control group was just the people randomly assigned to wait for 4 weeks. And I don't have here all the details if all the people were still going to see a therapist, and it was one group has in addition the TerraBot, so basically this GenAI tool, and the other nothing, or if everybody had at least also the help of a therapist. And the effect size were quite remarkable and strong. So I don't have here a good summary. It's always tons of numbers, and I don't want to throw these 10, 15 numbers at you right now and at the audience. But basically, I invite you to look at this randomized trial, control trial, that sheds some light on these questions and have promising results. I'm just plugging my computer at the same time. And yeah, so indeed, definitely, and this type of research shows that there is a potential for significant effect. If I'm not mistaken, it was I'm not sure about the numbers now, but a significant effect. And as you said, here the control group is not easy. If you think about causality, basically you want to pin down exactly what's the cause, what's the effect. Is it the overall effect, but also here of your service, basically? Or is it the fact that you journal, the fact that you journal plus the help, the fact that you journal plus the help plus the support group, all this mix of things? And also, what's the counterfactual? Do you want to compare to someone who is doing nothing? No, you don't. So what's the counterfactual? What will people do if your app will not exist? And that's the right comparison. But it's not easy to answer. What would they do? Well, maybe see a therapist, but maybe they struggle to find one. Maybe it takes 4 weeks. Maybe it takes a month. Maybe it takes a few weeks, but then you have also the financial constraint. I mean, how often you hear people, well, I would love to go see a specialist, but it's expensive. It's very expensive. They are very busy, mainly the good ones. So, I mean, it's tough to find support, and finding the right comparison is not easy in this setting. So thanks for sharing this. Also, here, because that's the thing I'm discussing every day, something that's particularly useful is now with causal AI, in particular, one set of tools that's called Causal Forest. It allows to go beyond the average treatment effect. So traditionally, in a randomized experiment, you just measure the average effect of the treatment, but we know that the average can be misleading. And actually, with Causal Forest, what you can do is detect heterogeneous treatment effect, basically detect subgroups who react differently. So maybe within the setting, you have a positive effect of, Safespace app, but then you detect that actually for a smaller group, it has no effect, or it has an adverse effect for some reason. And here in this era where we are clearly aware of the diversity of the richness of the people, it's a particularly useful toolbox.
So I would say there's definitely big potential in causal AI. Yeah, in as I mean, I'd say I like overall where like data science or I mean even economics is going in terms you're getting richer and richer data sets. Like it's even in our small pilot, for me it was quite interesting to have so detailed data, and we didn't even have access to the conversations. We just had like classifiers, but we had real time actions. So if one would write a message, the classifiers that we had in terms of emotionally opening up, and like what was the time of coming back, how long did it take for an answer. This just live data, and this allows for so much potential analysis, and so the tools to use, like we need to look at a lot of different tools to understand what's going on in the data.
And what about
And
privacy, by the way? Because here, I mean, what I was thinking is, what if someone says, I'm going to end it tonight? I mean, I'm done. I'm going to the train station and I'm going to kill myself tonight. Do you have like some things, some mechanism in the app that might trigger an alert? Or, I mean, how do you deal with privacy? Like, even if it's not someone, you see that during the conversation, it's getting there, but the person is not seeking help, is not seeking further help and contacting a therapist. How do you deal with this? Basically, the fact that you have the privacy concern, but also potentially you want to avoid something getting really bad.
so at the moment, we are dealing with it in the way that our pilot with ETH, like how the counselors ask us to deal with it, and that is when we detect a risk, we give a mostly hard-coded message that has been written by the counselors that advise on what to do,
Okay.
and we choose to stop the chatbot answer. So the AI doesn't really answer when there's a suicide risk involved. This was a discussion and it was a choice because you get to the point saying AI is not ready at the moment. So first of all, Safespace is not a suicide helpline. That's the first thing. Second thing, can AI handle it? Question mark. And the other point is, should we then not let the AI handle it? But would AI, even as it is now, providing some sort of advice or thing, be better than nothing?
But if you have, for example, in Switzerland, you have the 143 line.
Yes.
Probably it's 24/7. Maybe not
Yeah.
always, but I think so. It's 24/7.
Yeah. But there's different degrees of things. So there is a difference between having suicidal thoughts and being I think I'm not sure if the right word is actively suicidal or have active suicidal thoughts versus having suicidal thoughts. There's a difference in that, even in the degree of risk. So let's say there's like a stage, like you may have suicidal thoughts, but not be actively thinking, having a plan or thinking about suicide. And so it might be that when we detect in the app suicidal thoughts, there's a risk, and that could be handled or like would be better to have some sort of communication with the chatbot than nothing. Because in that stage, people are maybe less likely to call 143
Mhm.
because that's a hotline and it's like an ambulance will come get you. And that's scary, and you feel like you're not there. You are in danger, but you don't feel so in danger because you're not so actively thinking about it. So there are these. It's not black and white. That's what I'm trying to say. There are
Mhm.
it's a gray zone, And it's very hard to say what's the most appropriate response. And it may be even for a human. And what I'm saying is, for now, it's hard for a chatbot to draw the line. When is it that we go from suicidal thoughts to active suicide thinking? And like, should we let the chatbot handle the first one, not the second? What if we misclassify it? And so for now, what we chose is to, like, even whenever there's a potential, when the topic comes out, when the topic is detected even indirectly, the chatbot doesn't answer. And this is how we handle it for now. But what we do is that we, of course, send to our resources section that has like the numbers, easy to access, what time they are available, which languages, and things like this. This is how we chose to deal about it right now. But in the back of my head, I do have this in mind. Like, is there something that could some form of AI support even then be better than nothing?
Yeah.
But let's take small steps and see how things go with targeting mild to moderate symptoms of depression first. And then, as technology evolves, as we have more data, and as I would say, as we improve benchmarking for these classifiers, maybe at some point we will be able to have a better classifiers for that. And I mean, this comes together with what you mentioned earlier, like you were talking about detection. So this is more like risk detection or like distress detection. But people are doing research on detecting mental health disorders. And so I just see like this literature growing and growing, and then this classifier is improving, and then maybe we will be able to do something more. And just to mention, I think there's some research that is using LLM to diagnose psychosis. And so the point is, there are some conditions that might be, I wouldn't say easier necessarily, but like that might be or like, let's say, not easier for a LLM than for a trained therapist, but that could be more detectable than other disorders via text entry. So, for example, maybe there's some set of conditions that affect the way you speak, the choice of wording, the tempo of answering, the tempo of writing. There's so many components, and some conditions may be detectable via text input with the help of AI. And there's some research ongoing in this direction. And I honestly look forward to see this, because as you said, like two is better than one. Like, if you have a trained therapist, but they can get a support, maybe if even just flagging something to dig better. Maybe the chatbot is not able to dig more. This is like one issue that we have at the moment. They don't do so well multi-step thinking. And what they could do is just flagging, hey, like the usage of words, the tempo of answer, like that there's a flag for, like, I don't know, some kind of speech issue. And then the therapist then knows what is the multi-step procedure to dig more into that. And, they see a lot of patients. Like, they are human beings. They have possible errors, and these tools could just help them, reducing human error potentially. And we are not saying they should be replaced, just supported in what these tools can help with.
Yeah, it's very interesting. Indeed, I can perceive this evolution where basically the chatbot also have the capabilities to pre-diagnose. So basically within the conversation, it starts to ask the right questions to potentially have indeed, it flags something which leads to a decision within the chatbot. So I guess with maybe agentic AI later, you can have more complex exchange and evolution and choices and framework. Always connecting so far to a human at some point, potentially just as I mentioned, just pre-diagnose something, not replacing entirely. And this also leads to sometimes this discussion. We had this in learning. I'm curious also about just your thoughts on how it might impact inequalities. I mean, it can go both ways, right? It could be and let's say today, let's say in the future as well, in the sense it's due to the availability and cost of an LLM of a GenAI tool compared to a specialist, it might be less expensive. It's not replacing, it's different tasks as we have seen here. But there are always this risk that, well, at some point, richer people will get the great therapists, poorer people will get the chatbot. And I'm not sure about the overall effect, but I know that with respect to inequalities and in learning in particular, that's a constant discussion that exists. Well, great, let's create these tools that are better than tutors in this region of the world. And now we don't need to support them acquiring new tutors. They just have the chatbot. That might be basically, of course, a negative way of seeing it, of turning these results. But I don't know for mental health if you already thought about it and how you perceive this question.
Yeah, it's a tricky question. Let's say, I mean, I may argue back and say, but isn't that already what happens in countries that have no public healthcare, that richer people get access to therapy and the lower income part of the population doesn't? So maybe that population could get at least a tool that can help cases of mild and moderate depression not become worse. So I could see it that way. But on the other hand, yes, one idea is AI is not free, it's cheap, but it's not free. And especially targeting to some specific population like students, like it needs personalization for a specific disorder or a specific target population. And so one question that I also get asked is, okay, but where is the funding coming from? Like, we don't want Safespace to, cut off one therapist or one counselor from the university. And the way I see it is more like it improving or like guiding the people that need it the most to the counseling services, make it easier for them to handle the workload, in reducing potentially human error. Like, these are all things that would just improve basically the needed human component of therapy. But yeah, there is, I would say there is also this potentially bad scenario in which people would try to try to reduce the human component in favor of the AI. This is something that we don't want to happen. So it is always in the balance and in in the middle. As often it is, it's like the best way maybe in the middle and try not to I wouldn't want to see budgeting for therapists being cut to in favor of this AI. But it is a good thing that the technology is getting cheaper, and it will get cheaper. And once we have more data and literature, it will improve. And then hopefully this budgeting can just be seen as a sort of, doctors have tools already to work with. Like it's not that maybe they used to diagnose something by hand in the 50s, and now there's some tool that is. I'm a climber. Like, I can talk now. Like, they used to. It was hard to detect pulley fractures in the finger, and like in the recent years, they found out that they could be done better with echography, or I'm not sure of the word in English, but anyways, some tool. And this is what we are looking at. It's not like that tool replaced doctor wise, it just made them better at diagnosing the issue. And this is how I see this tool being used.
Which tool, by the way, are you using? Which chatbot is it based on? Safespace?
We use mostly OpenAI models as a base. And we are experimenting with Claude. Now we got some access also to like Gemini, and that's a bit my view on the topic of like what languages should we focus on, is that as a startup we cannot keep up with OpenAI or Google or Anthropic in creating a amazing language model. I mean, we for sure will like spend some times in like trying to like there's some llama models that can be a good start to fine tuning your own, and like we will definitely look into it like as we grow and like we get more like NLP specialists to work on that. But we can't make the new GPT 4.5 or like something that is better than that because we don't have the resources. And what we can focus on instead is like benchmarking these models, because not every model is good at doing everything, and not every model. So they are good at different things. And the new model, the new version of the same model, a reasoning model that is like an advancement on the previous one, may still be worse at doing some specific task. And then what matters for us at the moment is having an architecture and infrastructure that can guess any model. And with a state machine and benchmarking. This is what we are working a lot on now. For example, we have a new model. Can this model, does the safeguards we implemented still work with this? How does it behave in certain situations? We have new models for the classifiers. Does this new small model perform better in classifying the risk or like the emotionally opening up or like end of topic of conversation? Is it because the new model maybe is cheaper, maybe it's not cheaper, but it's better? Like there's always this. So benchmarking is the thing that we can work on the best as a small startup, because we are focused, because our focus is mental health and on a targeted population. And this is, I think, what we can add, what's kind of like our unique addition to the technology space.
Are you more hopeful or fearful about the future with GenAI and with respect to mental health at scale?
I'm hopeful, but I have to say sometimes when I look at the competition or some views or try some tools, I'm always afraid that not just funding being given to people with the wrong missions or so I hope that in the end we're going to be able to use the technology in the best way possible. And as an academic or partial academic, I think the way to do that is via research, because the more we know, the more data we have. Like there's never enough data. Like the more data that you have, the better it is, and the better you can assess things. That's like data are always the way to go forward.